Airway management. The term airway describes the anatomical structures that join the nose and mouth to the lungs. A patent airway is essential to life, so if air cannot reach the lungs, death occurs within minutes. Patients in critical care areas are often at high risk of airway compromise due to changes in neurological function, the administration of sedative and analgesic drugs, and the underlying disease process. They are also more likely to suffer cardiac arrest or to require mechanical ventilation, both of which demand advanced airway management techniques. Firstly, we will describe the anatomical and the physiological considerations as regards the airway. As we see, the airway can be divided into two parts, the upper airway and the lower airway. The upper airway includes the oral and the nasal cavities, the pharynx, and the larynx, while the major parts of the lower airway are the trachea, bronchi, bronchioles, and the alveoli. During normal quiet breathing, air is drawn in through the nostrils and passes through the nasal cavity into the pharynx. The mucosal lining, the cavity, has a rich blood supply. As a result, the air is warmed and humidified as it flows across it. And this effect is enhanced by the structures of the cavity, which is divided into two by the nasal septum and has scroll-like projections called turbinates that protrude from its walls. In normal health, the nose can sustain an airflow of 20 to 30 liters per minute. If the nose is blocked, for example by inflammation, or if greater airflow is required during exercise or illness, air is also drawn in through the mouth. Mouth breathing bypasses the warming, humidifying, and filtering effect of the nose, and as a result, colder, drier, and unfiltered air enters the pharynx. This has a desiccating effect on the airway, impairing the action of the cilia, mucus clearance is reduced, and the risk of pathogens reaching the lung increase, the risk of pneumonia. Ventilation via advanced airways such as endotracheal tube has a similar effect unless measures are taken to filter and humidify inspired gases. From the nose and the mouth, air enters the pharynx that serves as a common route for air and food. The pharynx is divided into three sections: the nasopharynx, the oropharynx, and laryngopharynx. At the laryngopharynx, the common pathway divides into two. Air is conducted anteriorly into the larynx, while food is routed posteriorly into the esophagus. The entrance to the larynx is guarded by the epiglottis, spoon-shaped flap of elastic cartilage. As we know, the epiglottis is normally open, but closes over the mouth of the larynx during swallowing, and this ensures that food and oral fluids pass into the esophagus and not into the larynx. Pressure receptors within the wall of the larynx initiate gag and cough reflexes if anything other than air entered the airway, so they can also initiate laryngospasm, a reflex constriction of the smooth muscle in the airway wall that clothe the lumen of the airway. During disturbed level of consciousness, the epiglottis is open and the protective airway reflexes are suppressed, so there is nothing to prevent secretions or regurgitated stomach contents from entering the larynx and passing into the lung. Aspiration of secretions and the stomach contents are common cause of pneumonia. Prevention of aspiration is therefore an important aim in airway management. The larynx contains the glottis, which comprises the vocal cords and the space between them. The vocal cords are essential to the production of speech and sound. They are also an important landmark during endotracheal intubation, during which a tube is passed through the cords and into the trachea. Below the larynx is the trachea, the first part of the lower airway. Like the pharynx, Its walls contain smooth muscle, however, it's also reinforced with cartilage rings, making it resistant to external compression and collapse. The trachea divides at the level of the carina to form the right and left main bronchi. The right main bronchus is wider, shorter, and more vertical than the left, and as a result, foreign bodies that are small enough to pass through the trachea will typically lodge in the right main bronchus, as well as an endotracheal tube that has been advanced past the carina. لأن أحيانا during endotracheal intubation بيحصل endobronchial intubation نتيجة إن حصل further advancement of the endotracheal tube past the level of the trachea. وبالتالي لو endotracheal tube advanced more and more, it will lodge at the level of the right main bronchus, as the right main bronchus is wider and more vertical than the left one. Each bronchus divides to form smaller bronchi and ultimately the bronchioles, the smallest conducting tubes. The bronchioles terminate in the alveoli. The alveoli are the air sacs where gas exchange with blood takes place. Airway obstruction. والايرواي obstruction من أهم المواضيع في الايرواي مانجمنت. نبقى عارفين الأول الكوزز اوف airway obstruction وازاي بيحصل airway obstruction وايه خطورة ان يحصل airway obstruction، وبعدها هنعرف التكنيكس to relieve airway obstruction. Airway obstruction can be partial or complete. In partial obstruction, the flow of air to the lungs is reduced and abnormal sounds such as snoring, gurgling, or wheezing may be produced. The patient may become hypoxic if there is inadequate airflow to the lungs. Whereas in complete airway obstruction, no air reaches the alveoli. The chest is silent and the breath sounds at the level of the mouth are absent. Profound hypoxia occurs rapidly. Without intervention, the person will die within few minutes. Preventing hypoxia is the most important aim in airway management. It requires an understanding of the causes of airway obstruction, accurate patient assessment, and knowledge of simple interventions to open the airway and maintain its patency. Common causes of airway obstruction: reduced level of consciousness, obstruction by soft palate, epiglottis, and tongue, aspiration of vomitus, blood, and excessive secretions, regurgitation of gastric contents, airway trauma, foreign body aspiration, especially in pediatric population, edema due to burn, inflammation, or anaphylaxis, laryngeal spasm, bronchospasm, pulmonary edema, external compression of the airway by tumor, hematoma, or trauma, and plugged tracheostomy tube by excessive and viscid secretions. Assessment of the airway. A person who can talk in sentences with no abnormal airway sounds is likely to have a patent airway. Speaking to the patient and eliciting response is a good initial assessment in the conscious patient. For individuals who are not fully conscious, or when there is doubt about the patency of the airway, look, listen, and feel approach is recommended. Look for what, listen for what, and feel for what. Look for chest movement and evaluate the work of breathing. If the airway is obstructed, the work of breathing may be increased and the use of accessory muscles may be evident. وهنفهم الwork of accessory muscles ده بيحصل ازاي. Observe the movement of the chest and abdomen. In normal breathing, the chest and abdomen rise together. If the airway is completely occluded, paradoxical breathing may be seen. If the person is wearing an oxygen mask, look for misting on the inside of the mask. If this is absent, no air is moving and out of the airway. وهتكلم برضو بالتفصيل في السلايدز اللي جاية عن paradoxical breathing. Listen for breath sounds at the mouth and the nose. If the person is wearing an oxygen mask, you will need to remove it to do this. Normal breath sounds should be quiet and unlabored. Noisy breathing and especially snoring and gurgling suggests partial airway obstruction. If no breath sounds can be heard, there may be complete airway obstruction. feel for breath on the cheek. What about the accessory muscles? As we know, during normal quiet breathing, inspiration occurs when the diaphragm and external intercostal muscles contract, lifting the rib cage upwards and outwards and expanding the volume of the thorax. During acute airway or breathing problems, additional muscles may be recruited in an attempt to further expand the lungs. These accessory muscles of inspiration include the sternocleidomastoid, scalenus, and pectoralis muscles. However, any muscle attached to the thoracic cage may be involved. Paradoxical breathing. In paradoxical breathing, the chest is pulled inward during attempted inspiration, while the abdomen is pushed out. The reverse is seen during attempted expiration, creating seesaw effect. Paradoxical breathing suggests that the airway is completely occluded, so emergency intervention is required to open it. وبنشوف البارادوكسيكال breathing ده during recovery from anesthesia أو during induction of anesthesia. During induction of anesthesia لو مفيش mask fitting during induction of anesthesia أو mask ventilation بالطريقة أو بالintervention السليم بيحصل airway obstruction، والايرواي obstruction هيديني paradoxical breathing. تمام. During recovery from anesthesia ممكن يحصل aspiration of excessive secretions أو vomitus أو blood from the airway. لو حصل aspiration ده هيعمل element of airway obstruction أو هيحصل laryngeal spasm، وده هيبروديوس seesaw effect أو paradoxical breathing. فمهم جدا إن يتعمل intervention السليم to relieve the airway obstruction to avoid إن يحصل profound hypoxia اللي ممكن تؤدي في النهاية إلى الوفاة. Opening the airway. عايزين نعرف إيه الانترفنشنز اللي ممكن تتعمل علشان relieve the airway obstruction وأمنع إن يحصل profound hypoxemia. ببساطة شديدة opening the airway means positioning the head and the neck so that the airway is as straight as possible and lifting the jaw to move the tongue away from the back of the pharynx. Before this is attempted, any visible obstruction طبعا should be removed. Start by opening the mouth and looking inside. لو في أي fluids أو في أي semi-solid material في الماوث أو الفارنكس لازم تعملها suction. تمام؟ طيب احنا عارفين ان الاندوتراكيال intubation والاكستوبيشن والسكشن والمانيوال فنتيليشن والهاي فلو نيزال اوكسجين كل دي بسميها aerosol generating procedures. بمعنى ان الريسك اوف انفكشن هيبقى عالي جدا جدا جدا، فلازم تاخد كل البريكوشنز بتاعتك سبيشالي واحنا في الكارنت بانديميك اوف كوفيد 19 نخلي بالنا واحنا بنعمل سكشن كويس قوي. الايمج دي بقى خاصه باليوز اوف ماجيل فورسبس تو ريليف ايرواي اوبستراكشن. ان الماتيريال اللي موجوده في الاوروفارينكس ممكن تكون سوليد، وبالتالي مش هينفع ان هي تتشال او يحصل لها ريموفال بالسكشن، فلازم نستخدم ماجيل فورسبس. هنا بترفع باللارينجوسكوب عشان تعمل good visualization of the solid material obstructing the airway, then remove it by ماجيل forceps. تمام. وبعد كده هتمنتين بالاكسجين. في طبعا different types of catheters او suction cath. في عندنا soft suction cath دي اللي هي فوق can be advanced further into the airway، وفي عندنا الهارد suckers ودي موجودة at the bottom should only be used within the oral cavity to avoid airway trauma. So what are the techniques to open the airway؟ أنا دلوقتي المرحلة الأولانية عملت good suctioning، رفعت باللارينجوسكوب، عملت removal للسوليد ماتيريال بالماجيل فورسبس. طب open airway ازاي لو البيشنت ده unconscious patient؟ تفتح الايرواي ازاي لو في element of obstruction after removal of the solid material او السيمي solid material او السكريشنز او الفوميتس؟ عن طريق head tilt chin lift maneuver. head tilt بكل بساطة بتعمل tilting الهيد by one hand والاذر hand بتعمل بيها chin lifting. ومهم جدا ان الهاند اللي بتعمل بيها chin lifting ما تعملش compression على السوفت tissues، لان لو حصل compression على soft tissues of the throat هت augment airway obstruction. طيب احيانا بيكون سبب الايرواي اوبستراكشن ان حصل سيرفايكال كورد انجري في الار تي اي. ممكن يحصل سيرفايكال كورد انجري، والسيرفايكال كورد انجري دي اي موفمنت للهيد او النك هتبقى دينجرس، ان ممكن تعمل سباينال كورد ترانسكشن، تمام، وتزود النيورولوجيكال ديفيسيت اللي موجود عند العيان، ممكن تدخله في الكوادريبليجي. في هذه الحاله الجو ثراستنج هو هيبقى the best for relieving the airway obstruction. So if a spinal cord injury is suspected, it's undesirable to move the neck. In this case, use a jaw thrust instead, maintaining the head, neck, and the chest in neutral alignment. We have to place 2 fingers behind the angle of the jaw and forward thrusting or lifting the jaw upward and forward while using the thumbs to open the mouth. If these measures are successful in opening the airway, we have to apply high flow oxygen using face mask with reservoir bag and oxygen flow rate 15 liters per minute, then reassessing the patient using ABCDE approach. If the airway remains occluded despite these simple maneuvers, always consider the possibility of shocking. Suspect shocking if the person develops a persistent cough or sudden breathlessness during or after eating. طب لو في persistent cough during eating, you have to encourage the patient to cough. Continue coughing، لأن السترونج coughing ده هيزود البريشر في الايرواي، وبالتالي هيساعد ان الاسبريتد ماتيريال to get out of the larynx. طب لو حصل complete airway obstruction and the cough is weak or absent، وقتها بنعمل حاجة اسمها هيمليك مانوفر، أو بنعمل back blow or abdominal thrust to clear the obstruction. Maintaining airway patency. طبعا following successful opening of the airway, we have to maintain the patency of the airway by using airway devices. في عندنا simple airway devices زي الأوروفارينجيال والنيزوفارينجيال airway devices، هنشوفهم في السلايدز اللي جاية. وعندنا advanced airway device زي السوبراجلوتيك devices والإندوتراكيال tubes. الأوروفارينجيال والنيزوفارينجيال airway ليها limitations. أول حاجة مش بتprevent الاسبريشن، هي بتمنتين البيتنسي of the airway طبعا، ولكن they don't prevent aspiration. During cardiac arrest, they don't permit continuous chest compression or the measurement of end-tidal carbon dioxide. لكن السوبراجلوتيك airway devices والendotracheal tubes تبقى more advanced أو more definitive airway management, especially في unconscious patients. هل إحنا في limitations للسوبراجلوتيك devices أو الendotracheal intubation؟ ده اللي هنشوفه في السلايدز اللي جاي. أول حاجة الأوروفارينجيال airways. الأوروفارينجيال airway is a curved plastic tube shaped to fit over the top of the tongue, with one end between the lips and the other end in the oropharynx. It's commonly described as giddle airway. Wide range of sizes are available for adult زي اللي قدامنا في الصورة، size 3, green, size 4, orange, and size 5, red. دي commonly used. The oropharyngeal airway is sized by placing it vertically against the patient face، بحيث ان التيب تبقى موجودة عند الانجل of the jaw، تمام، والintegral bite block should sit between the patient incisors. ودي من الحاجات المهمة جدا جدا جدا، ان لازم يكون الintegral bite block should sit between the patient incisors، اللي هي عند الجزء الكالرد، سواء الجرين او الاورنج او الريد او الالوان التانية اللي موجودة في البيدياتريك، اليلو والوايت وكده. An oropharyngeal airway is inserted into the mouth upside down, in other words, with the end curving upward toward the roof of the mouth. The airway is pushed inward till it reaches the soft palate. At this point, it's turned through 180 degrees and advanced till the bite block is between the incisors. And this method of insertion helps to prevent the tongue being pushed back into the airway. بمعنى أصح، التيب of the airway تدخل الأول curved ما بين الانسايزرز، وبعد كده بقلب الاير واي 180 درجة، تمام، بحيث ان الكيرف ده يبقى upward at the level of the roof of the mouth، تمام. وقلبته 180 درجة دي هدفها ان امنع ان التنج يبقى pushed back into the airway، لان لو انت حاولت انك تحط الايرواي والكيرف بتاعه upward من الاول ممكن تعمل pushing للتنج وتعمل more and more obstruction of the airway. الاوروفارينجال airway tend to cause gagging، هيستيموليت الجاج ريفلكس till the patient is profoundly unconscious. If tolerance is a problem, nasopharyngeal airway may be a better choice. يبقى موضوع الجاج ريفلكس ده من الحاجات السيئة جدا وبتقلل التوليرانس للاوروفارينجال ايرواي، تمام. لكن لو البيشنت completely unconscious patient او عنده disturbed level of consciousness او جلاسكوما سكيل بتاعه قليل، ممكن ان احنا نحط الاوروفارينجال ايرواي. في الكونشس patients يفضل to relieve مثلا السنورنج او recovery from anesthesia nasopharyngeal airway بيكون افضل والكومبلاينس والتوليرانس بتاعه بيكون احسن. تاني حاجة عندنا nasopharyngeal airway. Nasopharyngeal airway is a soft flexible tube with a flange at one end. It's inserted via the nose with the end passing through the nasopharynx and into the oropharynx. The flange sits at the nostril to prevent the tube from being aspirated. A variety of sizes are available, although 6 mm and 7 mm tubes are commonly used in adults. Insertion is simple. The airway is lubricated along the sides, but not the tip, with water-based lubricant and then gently twisted into the nostril. The right nostril is typically larger and straighter, resulting in easier insertion in most people. If insertion is difficult or complicated by bleeding, we have to try the other nostril. Nasopharyngeal airway generally well tolerated even in patients who are conscious, but shouldn't be used if there is suspected basal skull fracture to avoid the risk of nasocranial insertion. Then we will talk about the supraglottic airway devices. Supraglottic airway devices were developed as an alternative to the endotracheal tube during routine surgery and are now widely used in this setting as well as during cardiopulmonary resuscitation. The first widely used supraglottic airway device was the laryngeal mask airway, which consists of an oval inflatable cuff attached to a tube. The cuff seals around the entrance to the larynx or laryngeal inlet, thereby providing some, though not absolute, protection against aspiration. The iGel is a pre-shaped cuffless supraglottic airway device which sits in the same location as the laryngeal mask airway. It has some advantages. It's quicker and easier to insert than laryngeal mask airway. It provides also a similar level of protection against aspiration, but not absolute protection. Its ease of insertion has led to its widespread adoption in resuscitation services, as well as anesthetic department. Nurses and other non-medical staff can be taught to insert it with minimal training, like the oropharyngeal airway. Adult iGel sizes are 3, 4, and 5. A size 3 is aimed at a small adult 30 to 60 kg, size 4 for those weighing 50 to 90 kg, whereas size 5 for those weighing 90 kgs or more. The airway should be held firmly by the integral pipe block with the air outlet facing the patient chin. The airway should then be slid along the roof of the mouth and drawn into the pharynx till a definitive resistance is felt. The integral pipe block should be between the patient incisors when it's in the correct position. Endotracheal tubes. Endotracheal tube is considered the definitive airway device because it enters the larynx passing through the vocal cords. Most tubes have inflatable cuff which form a seal between the tube and the wall of the trachea, and this provides a higher degree of protection against aspiration than any other airway device, although this does depend on the integrity and the correct inflation of the cuff. So under-inflation of the cuff can allow secretions or gastric contents to bypass the cuff, contributing to aspiration pneumonia. In contrast, overinflation can cause pressure damage to the tracheal mucosa. Recommended cuff pressure is between 20 to 25 or 30 cm water. Intubation with an endotracheal tube takes place under direct visualization using laryngoscope. The procedure takes considerable training and practice to master. Misplacement of the tube in the esophagus is a common complication, and if unrecognized may lead to profound hypoxemia and cardiac arrest. Correct placement of the tube should always be confirmed using clinical assessment such as chest expansion and auscultation, alongside detection of exhaled carbon dioxide using endotidal CO2 detector. As we see in the image below, this is the classical waveform drawn during esophageal intubation by the capnography. Air that has passed in and out of the esophagus will not contain a significant amount of CO2, unlike air that has ventilated the lung. The presence of significant amount of carbon dioxide in exhaled air is a reliable indicator of successful endotracheal intubation. So clinical assessment should be performed alongside this to confirm that air is entering both lungs, as a tube which is advanced too far may be placed in the right main bronchus and therefore ventilate the right lung only. وبالتالي endotidal CO2 detector can detect esophageal intubation by drawing this waveform but cannot detect endobronchial intubation significantly. So auscultation of the chest is mandatory, or clinical evaluation of the patient plus the use of essential monitors like capnography is essential to detect this catastrophic event, esophageal intubation. This image describes the endotracheal tube. The size of the endotracheal tube demonstrated at the proximal end of the tube, 7.5 mm internal diameter. At the distal end of the tube, the distal opening and the Murphy's eye, this is another ventilating port, as a substitute to the distal port if it's blocked by mucus plugs, and inflatable balloon. The pressure inside the balloon should be within 20 to 25 or 30 centimeter water. This is the distal end which pass in between the two vocal cords in order to ventilate the lungs.